Welcome to the Pediatric Obesity Grand Rounds, presented by the Department of Pediatrics at Kings County Hospital. First, we're going to start with a short video depicting what our patients' ultimate outcomes could be without interventions.
All right, what do we got?
Just came in. Heart attack. 5'9", 300 pounds, 32 years old.
How the hell does that happen?
Can I get a, Could be developing diabetes. You have to make a change. Oh, yeah.
You're graduating! Watch TV. You won't even have to leave.
You can't do this.
Yes, can I get a...
Yeah, no, deep dish.
You have to make a change. Good job, Jim. You got an A+.
There are your fries, sweetie. You go.
I still can't believe you give this child French fries.
I know, but it's the only thing that'll make him stop.
These were the objectives that I had sent out that we're going to try to cover. However, this is really the objectives that I would like to try to cover. To help you learn that adolescents may need bariatric surgery and it's safe, and so are the meds we think. We want you to know why our patients can't just lose weight no matter how hard they try sometimes. You need to be referring overweight and obese patients and their families for help, or else after years of chronic disease, they're gonna die prematurely. And if there's nowhere to refer to, then we should be the center of excellence in all aspects for obesity medicine. And then, if all else fails, just help treat obesity in adolescents before they become another statistic that we'll see today. So you have read, you've heard, you've seen all the complications of obesity. These are not necessarily children, but this is obesity in general. And you can see they correlate really well with the top 10 leading cause of death in the United States. And when there's accidents, obese patients have 30% risk of morbidity and mortality above non-obese patients. And I think the rest kind of speak for themselves. And in fact, COPD, obesity may actually prevent worsening COPD. However, those studies are still kind of contradictory. Right now, we see that 1 in 3 children are overweight, and 1 in 6 are obese. When we look at the world, we see that there is a significant rise in obesity. This is looking at the girls throughout the entire world. Our demographic is this blue area, which is the largest area on this graph. When you look at underweight or severe underweight, we see that for the most part, it is starting to fall from where its peak was. So while we're falling in severe underweight, we're gaining in obesity. This is the graph for boys throughout the world. And if things don't change, roughly 2 out of 5 girls will develop type 2 diabetes in their lifetime, and 1/3 of boys will develop type 2 diabetes in their lifetime. But the problems that we're having right now is that about 60% of overweight 5 to 10-year-olds have cardiac risk factors. 25% of obese 5 to 11-year-olds have high blood pressure, and 36% of children with obesity have hyperlipidemia. We also are all aware of metabolic syndrome. 18% of our adolescents have prediabetes, and 30 to 50 of them have metabolic syndrome. And if we keep seeing this trend continue, 1 in 3 of all children, boy or girl, born after 2000, will have type 2 diabetes in their lifetime. So we're seeing obesity-related illnesses are in the realm of 190 billion in the United States. Businesses suffer from obesity-related illnesses, and childhood obesity alone is resulting in about 14 billion in direct medical costs. So in 1965, we really had our first introduction to mainstream TV dinners, which was the easy cook foods that we had at home. And today we have pretty much, I would say, 50 to 100% of what our family eats is these quick meals. Me and my wife, we just don't have the time to cook that we really should. And so a lot of our diets are being comprised of all of this food that may not be the healthiest for us. We all know the debacle with Coke, and Coke bottles are increasing. But to really give you a perspective, if you go to 7-Eleven or any of its competitors, they have up to a gallon-sized jug of soda that you can buy now. So we could look at Starbucks, because our adolescents and us are really going to coffee shops more and more. And you could say, oh, it's just black coffee. However, the dark mocha frappuccino is their #1 seller, and the 29-ounce, which is bigger, results in 1,080 calories in one sitting. So if any of you are currently getting the dark mocha frappuccino, I would consider changing your options. Another way to look at how we got here is how active we are. So if you look at one side of this, where Switzerland is, you see that they have an obesity prevalence of just under 20, and everybody is active, or at least over 60% of people are active. When you look at the opposite side, you see that in the U.S., the amount of people who are active or are using some type of physical transportation is less than 5%. Is less than 10%. And our obesity is somewhere in the realm of around 25. So then, if you look at trips taken, this is from the same study, cycling and walking in public transportation, you can see where we are again compared to Switzerland. And I mean, Latvia is killing it over there. But if you look at Switzerland, they have the highest number of walkers. And then everyone will say, yeah, that's well enough, but we can go to gyms, we can do this, we can do that. But there's lots of reasons why we can't actually lose weight. So on a soapbox, we can talk about that the food industry is just making tons of money a year, $1 trillion a year with $450 billion in gross profits. So if you're looking for a company to invest in, you may want to invest in one of them. Healthcare costs are around $3.2 trillion a year. And again, while obesity may not be all of them, we have 75% is chronic metabolic disease, and 75% which is preventable. And about 1.5 trillion is wasted on preventable diseases without preventing them. So if you're wondering which food companies I'm talking about, they're all the common ones. And the majority of foods that we'll wind up getting from a supermarket that are not fresh foods fall into these categories. The other thing that is great about these companies is if you look back, we can't look at the recent recession, we don't have enough data yet, but if you look at 2009, the S&P fell by a lot. However, McDonald's, Coke, and Pepsi had a much better recovery than the S&P did over the next 2 years. McDonald's also looks like it might be recession-proof, not this most recent recession because all the stores had to close, so it doesn't have the same curve. And then I don't know if this is good or bad, but look at the top 10 pharmaceutical companies in 2020. They are making tons of medications for diabetes, some for obesity, but for asthma, for all the chronic diseases that we're treating in patients with obesity. They are making money off of all those medications. So while they may be trying to make medications to help us fight obesity, they are also making the medications that will get hurt if we fight obesity well. So I don't know what their ownership is or where they are more focused. We cannot cover all these reasons. There can be a 2-week course on all of this, and you still cannot cover all of the reasons that we have difficulty losing weight and what affects our weight management. When you're trying to lose weight, you start to lose weight rapidly, and then you'll have a leveling off period, and that's where you see our loss with a steep curve down to 0. So 0 is where you hit your maximum amount of weight loss. Everybody will regain weight once they hit their maximum weight loss. Now, you may say, no, I know people who haven't. That's okay. They may not have. They may not have regained adipose tissue, but everybody regains weight because if you are really going to be an insane workoutaholic, you are going to wind up needing to work out about 480 minutes a week to stay in that maintenance period, keeping off all the weight. And if you're going to be doing that, you will be gaining muscle weight. So everybody will regain weight. But to be able to really keep off that adipose weight, you're going to have to work out that much and continue to have an extremely healthy diet in the world of nutrition not going the way that it should. There's many hormones involved with keeping us fat. I'm just going to touch on a few of them because they're the easiest to understand. So the first one that I'm going to highlight here is ghrelin. Ghrelin is produced by the greater curvature of the stomach, right? So it's produced by this large part of the stomach here, and it's the only hormone that makes us hungry. The rest of them, as far as we know, result in satiety, making us feel like we're full after we eat, or making us have the urge to want to eat something. Not make us hungry, but make us want to eat something. Those are two separate ideas. So when you have ghrelin surging from your stomach will growl and you're going to eat. Leptin we're going to talk about very closely, and insulin and inulin both play a large role. Insulin, as it drops after you've taken in a large sugar amount, you try to keep your insulin levels up again, and you'll feel less satiated if they don't spike high enough. Same with PYY and GLP. So again, this is the normal curve of what you see when people are losing weight. They were on a large diet phase, and they start to regain weight, and they eventually settle out somewhere over here. When we look at ghrelin, as you lose weight, your ghrelin levels will rise even more. So it's a way to look at this. This is ghrelin, and this is over minutes after you eat. So as you look at time 0, that's when you eat. You're going to have your ghrelin levels at a certain amount. So our baseline level before we started dieting is this black line. And you look at this black line here, and then it goes down and comes back up. And then you'd go and eat again later on here because you feel hungry. 10 weeks later, meaning at maybe while you're at the peak of your weight loss or while you're really having rapid weight loss, your ghrelin levels, when they're at their peak, are close to even double what they were before. So you are even hungrier than you ever were before. And then even after you eat, your ghrelin levels are relatively staying in the same area where they were before you started dieting at their peak. So you are going to be hungry here, hungry here, hungry here, hungry here. And then after about 62 weeks after your weight loss and you've regained some weight, your ghrelin levels remain elevated. Your body has found a new homeostasis and wants to get back there as hard as possible. This is what has made us survive through famine. We find food and we eat it. It's what drives us to live. When you look at peptide YY, this helps with satiation. The higher the level, the more satiated you are. So before we started dieting, the black line, it was higher. When we started dieting, it was lower. And when we got back to, after we regained a little bit of weight later on, it's even lower. So we're less satiated, more hungry than we were before, and we're still trying to keep that weight off. Your desired, and then when they asked all these participants how they felt for hunger and how they felt for their desire to eat, again, they followed the curves that we've shown so far. So when we want to look at leptin, leptin is produced by fat cells. So if you have large fat cells or adipose tissue, you're going to be producing more leptin, and your brain loves leptin. It just wants it. It wants to feel good about it. So as leptin falls, your body thinks something's wrong, and you need to have more fat stores. So in times of famine, your leptin would fall. In times of feast, your leptin would rise. Your brain would feel great, and you may not eat nearly as much. An easier way to look at this is you can see this is homeostasis. This is normal. We have a normal amount of adipose tissue with a consistent amount of, leptin. Now you're dieting. You lose some fat, and now you have significantly less leptin going to your brain. And your brain is making you now feel more hungry. So then you start eating a lot, and you bring your adipose tissue back to where it was, because your body keeps trying to go back to where it was. and you start producing leptin appropriately. And then you go on a cruise, you have a holiday coming up, and you just eat and eat and eat. And now your adipose tissue is going to get even larger, and you start producing even more leptin. Now, once you start producing that, you usually will wind up eating a little bit less because your brain's like, whoa, we don't need all this amount of leptin. And then you'll go back to the weight that you normally were. People who do not struggle with weight do this normally all the time. And they say, yeah, after I eat a lot, I just don't feel hungry for about a week. And this is one of the reasons why. However, we have this thing called the leptin trap. It has a number of other names. Once you eat a lot for a prolonged period of time, your brain kind of resets the thermostat as to how much leptin it wants to eat, or it needs to have. So once you reset that level, you are now going to need more adipose tissue to meet that demand. And unfortunately, we have not figured out yet how to get the body to reset at a lower level. So again, we could go through all of these other things. I've only touched on a few, but each one of these aspects has a very negative reason as to why we're unable to lose weight.
The World Health Organization says the number of obese children and teens is now 10 times higher than it was 40 years ago due to poor nutrition and lack of exercise. The problem is more than just physical.
Social, psychological problems for the children themselves, more stigmatism, more bullying.
An online study in the journal Lancet found that obese children tend to be overweight as adults.
It's also more likely to lead to earlier onset of conditions like heart disease, cancer, and diabetes.
Experts analyzed data from 2,400 different studies that track the height and weight of 32 million children 5 to 19 years old. The research shows an estimated 74 million boys and 50 million girls are obese worldwide. Obesity rates are still rising in poorer nations that have leveled off in countries like the U.S. and here in the U.K.
All right, so one thing with that video, it's just to give me a break to get a drink of water, but also they said that rates were leveling off. And that was from the WHO about 2.5, 3 years ago, I think, 2017. And if you look at NHANES data from, this was published in 2015, you can see that from 2009 to 10 and 2011 to 12, down in the blue, it looked like we had the same total rate of obesity. And again, that's BMI greater than the 95th percentile for age, at 16.9 and 16.9. And we had a decrease in the 2 to 5 year old age range and in the 6 to 11-year-old age range. But what we did see is that despite we were seeing decreased rates, there was a significant increase in the amount of class 3 type obesity, which is the largest category of BMI. Now, when 2 years ago, when the CDC came out with new data, as well as NHANES, we saw that that might have been erroneous, what we saw the previous time, and that our rate has now jumped from 16.9 to 18.5% prevalence, with an increase in both 2 to 5 years, 6 to 11 years, and 12 to 19 years. So we thought we had things under control, but we don't. And we have so much against us in trying to make a difference for our kids. This is the same data populated out since 1963 for our 3 different age groups. And our adolescents, if you pay attention, are in the 12 to 19 years there in the blue. This extra blue line, which is higher, is our adult obesity trend. So you can see it's starting to go into exponential growth. One thing I don't think we often think about is the good-looking baby born in, say, 1980. He jumped up onto the curve here if he was taking too much juice, French fries, and so on when he was a baby. Again, I have nothing against French fries. It's just an easy thing to talk about. And then he got, became around 5 years old and then jumped up to the next curve. And so from there, he came to 11 years old, and he's part of that pop. He's not necessarily gaining more weight. He's just staying in that same greater than 95th percentile curve. And it's just growing, but his peers are growing in size. And then he jumps to the adolescent curve and goes on up to 18 years old, and then moves off to college. And once he moved off to college, he jumped up into this curve. And that curve just keeps growing, maybe shrinking, growing, maybe shrinking, until it's really growing, until we're here in 2020 and I don't know, I could look a little better. The problem is all of them are going to die eventually, but many of them may be dying prematurely. And unfortunately, that jump up to the adult curve, we have 90% of obese adolescents are remaining obese in adulthood. And children who are diagnosed with obesity are greater than 2 times more likely to die prematurely before the age of 55 of endogenous causes from pathophysiology related to chronic disease. And the first one is just showing when the children were diagnosed with obesity. The first block, you can see there's almost a 4 times difference in the rate of death. You can see that there is in 10 to 15, it's about 1.5, and in 15 to 20, it's about 1%. A 1 times difference. So why are they dying? Well, there's a host of chronic diseases that they all get, which we already mentioned before. I'd like to just mention a few more to specifically to just make you feel bad. So hypertension is one, and we've seen right now that anywhere between roughly 4% to 25% of adolescents with obesity have hypertension. There's a 2-fold increase when their BMI is the 95th to 98th percentile in all children, and a 4-fold increase when it's greater than the 99th percentile for all children. Hypertension is also a significant risk factor for developing renal disease, cardiovascular disease, and ultimately increasing their risk of death. So I showed this slide earlier that 25% of 25% of children 5 to 11 years old with obesity have hypertension. What I'd also like to show you is that same study that showed the increased risk of death less than 55, that children with hypertension were 1.6 times more likely to die early than any of their peers. Diabetes. So we know that as you gain weight, you're going to increase the risk of diabetes due to insulin sensitivity. We also know, well, I'll talk about it on the next slide, but insulin sensitivity also increases your risk for cancer. We know that globally, diabetes continues to rise. This data is old, and it is actually a higher number now, but I can't get a consistent one to publish that has been published. So if we look at 422 million people who all need glucose strips, not that they all can get them, but let's say they could, they'd be using 3 a day for 365 days a year, and that would be $523 billion a year. So why on earth would they want to decrease their profits? I don't know. So again, looking at cancer, we know insulin resistance increases the risk of endometrial cancer, and that obesity is also associated with breast cancer and prostate cancer. And no matter what cancer you have, if you are obese when diagnosed with that cancer, you have an increased risk of morbidity and mortality. Now, there's another study even more recently published in 2017 that showed that there's an increased risk of death in children with obesity under the age of 35, not just 55. In the video that we watched at the beginning, they said that gentleman was 32. So adolescence is a time period that we can maybe do something more. And the reason I'm focusing, I'll get a little bit more while I'm going to focus on the adolescent, is to introduce you to programs that we have at County that we can actually hopefully start to make a difference. But we need a lot more people to help us. So adolescence is a very critical time to address obesity. There's lots of physiologic changes and insulin changes during puberty. Early menarche is also associated with a risk of increasing obesity. And we already showed that your risk of becoming an obese adult is high when you're a child with obesity. So we always talk about a family-oriented, or I hope we talk about a family-oriented approach. This is how we should be approaching all our patients. The question is how to do it right. I can't answer that today. That takes a lot of time to answer, and we need to really look at how some of the other centers are doing it best. One of the best that I know is up in Boston at Boston Children's, or it's Harvard, Boston Children's, and MGH are working all together, where they have a specific food pantry for patients who are enrolled in their program. And as long as they go to regular appointments, they have some of the best possible foods you can get. It's an amazing test kitchen and everything. We are not at that level, although I'd like to be. So when we have our parents and our children, we cannot control our environment, but we can control what the parents learn. And hopefully, by helping the parents make better decisions, they'll teach the children to make better decisions, or vice versa. When we looked at this study that looked at teaching the parents, teaching the children, and putting them on a program together, they were able to show both after initial weight loss and 12 weeks after the program had ended that the parents who lost weight had the children who lost the most amount of weight. Here it's change in BMI, but I'm just using weight to make it a little easier. So if we can help the parents lose the weight, our children will do better. And if our children do better, their children hopefully will do better. We also know healthier physicians will be healthier patients. I know every single person listening to this right now knows how to be healthy, but it's just hard. It is so hard. I have tried to lose weight, I don't know how many times. I haven't done surgery, but I've done everything else. And I know it, and I know it, and I know it, and some days I just don't want to do it. So I keep fluctuating from the same 180 all the way up to 220. I go back and forth and back and forth. But I think because of it, I have a healthier mindset. I don't know if I have a healthier mind. And I do try to counsel patients all the time about it. So lifestyle modifications. You may have positive or negative ideas about lifestyle modifications when talking to your patients. In our setting at County, it is really hard to counsel our patients in the short amount of time that we have to be able to really make a difference. But they are listening. They are listening. I don't have the stats here today showing you how parents listen when you talk to them in a genuine way. I do not have any information on this today, but there is the concept of what's called motivational interviewing. I will have resources for everybody for that after this, to do a course in motivational interviewing or to just be able to read more about it. Motivational interviewing is the idea that you let the patient speak, and we're not criticizing them for their weight. We're not criticizing them because they can't follow the plan. We're helping learn from them what they think they can do to improve compliance. So I want you to understand that when I talk about talking with families, it's not telling them, it's understanding them and letting them really tell us what they want to do, and then filling in some knowledge gaps as needed. So back to lifestyle interventions. We know that they work. They work in overweight children, not children with obesity per se, or definitely not in children with a BMI greater than 40. But in children who have a BMI between 25 to 34, we know that they work, and we should continue to work on lifestyle interventions. When we talk about lifestyle interventions, these are some of the examples that we have as far as a healthy diet. Now, if you look at the BMI greater than 120th percentile, really that's what we all should be doing anyway. It's not anything that's earth-shattering as far as what people should be doing as far as dietary guidelines. And I know all of you know this already. This clip is taken from the Pediatric Obesity Algorithm published by the Obesity Medicine Association. I'm going to make that available. I think it's illegal for me to make available for everyone, but I'm going to make it available for everyone so you can read through it and really understand everything you should understand when you want to talk to your own patients in clinic. This, again, is also taken from that. Now, this is how they recommend management of the adolescent with obesity. Read just very quickly through this slide, and you'll see all of these things. These are not easy things to do. You cannot teach all of this in an appropriate way in a 5-minute session. Including your physical exam documentation and everything. And this is the activity that we're talking about for adolescents. They're expected to do at least an hour a day of one of these active exercising. I don't do it. I try for like a month or two, but this is extremely hard to do. And I live in the suburbs. I have a job. I have money. And we're asking families who don't live in the suburbs or who may not have the same resources that all of us have to do these things. And on top of that, if you look at the 2 precincts that surround our hospitals, these are the crime statistics, major crime statistics. These are not, I'm not going to put up the minor crime statistics, which are much more. It's a total of 8,762 major crimes in the 2 precincts that cover our area. And you can see our red dot at the top there is Kings County and downstate. And then 2 weeks ago, from the 11th to the 8th, there were 39 major crimes. So GLA is grand larceny auto, and GR is grand larceny. So to add, from the 2nd to the 8th this month, There were 2 shootings, there were 43 petty larcenies, there were 19 misdemeanor assaults, there were 2 other sex crimes, and year to date, in these 2 precincts, there have been 77 shooting incidents and 112 shooting victims. So are you going to have your kid go outside and, run or ride a bicycle as far as they can go? Or are they going to go, after all the schoolwork is done in the evening, to a dark field to go play soccer with, 20, 30 other people safely? I don't know. I don't know if that's possible right now. I wish it were, but I don't know. One thing that we should all be doing better is sleep. So these are the current recommended hours of sleep. You know this. What I'm not going into is all the science behind sleep related to weight gain. If you are chronically sleep deprived, all of those hormones that we talked about earlier, plus more, are going to be out of whack and will drive you to eat. That's why if you're post-call, you need to sleep, not eat. But we've all gone through periods where we become hyperphagic and then we pass out after a 24, 36-hour call. If they can't get the recommended, at least remind them to avoid the definitely do not do's. There's a stepwise approach in trying to approach the patient with obesity. So intensive lifestyle training is on all of us, for our families, for our friends, for our patients. And then as primary care physicians, we should focus on adjusting weight-promoting medications. I'll touch on that quickly, but I will give you a list of medications that are weight-promoting after this today. Then there's pharmacotherapy, although lacking in adolescents because not a lot is approved to use, and we don't have great results so far. There's emerging bariatric technologies that we'll talk about as well, or rather bariatric surgery. And then there's the ongoing management. Once they lose weight, they're all going to gain weight again. And if they're not being physically active, they're going to gain weight again. I don't have these studies up here today, but it's been shown the only thing that really helps keep the weight off in that maintenance phase is a lot of physical activity, 480 minutes per week. All right, so let's talk a little bit about medications. This is a quick slide on some of the most common medications that are prescribed in pediatrics that will that will increase patients' weight gain. So when we're looking at is that first and second box with significant weight gain and small to neutral weight gain. I'm sorry, I am not reading it off if anyone's on the phone. All right, so then we have medications to actually help treat overweight and obesity. So one of the few, the one that's been approved the longest in pediatric patients is Orlistat. Ally is just one of the many now because it's off patent. However, it's approved for children greater than 12 years old. However, it has a significant rate of non-compliance in adolescent patients. It causes the worst gas, farts, and oily stools. It can also cause incontinence. So you could have a kid sitting in class busting a gut because he's laughing so hard at a joke, and then all of a sudden he has an accident. This is not something that our patients will want to put up with. So there's an extreme non-compliance with it. And overall, it has a low rate of improvement in weight loss. Metformin is another one that we've been using for years. It's approved for children with type 2 diabetes and also for metabolic syndrome now for greater than 10 years old. However, it's not uncommon that patients will wind up getting some GI upset. It's great for their prediabetes. However, it is not necessarily great for weight loss, although it does help. Topiramate, an anti-epileptic, which we've been using for years, is not FDA approved in children for weight loss, although it is for adults. And also it can cause some paresthesias, tingling in the fingers, and cognitive disruption. It can also mimic RTA, renal tubular acidosis, by wasting bicarbonate. So there is a degree of noncompliance when taken by adults, although it's not at all FDA approved in kids. Some people are trying to use it. Phentermine, this is now, since the last time I gave a talk on this, this is now approved. It was approved about 1.5 years ago, 2 years ago, and for children greater than 16. There's a lot of warnings and precautions. If they have hypertension, maybe they could use it, but it's not contraindicated in hypertension, but it's not recommended because it can increase blood pressure and heart rate. It can definitely increase anxiety, tremors, and we don't prescribe it much at all in adolescents, although we should consider trying it. There are no great studies showing how well it works yet. Phentermine topiramate is also known as Qsymia. It's a very expensive drug, often not covered by insurances. And then for pediatric use, you could try it, but they'll have to pay out of pocket for this around $120 or so for every bottle. So that's about 30 capsules. And it's not approved for pediatric use, so I'm not recommending its use. And also there is a black box warning for 18 to 24-year-olds because of the increase in depression that they see. There's another drug, azenatide, which did not get great results overall for pediatric patients. For adults, it seems to be great, although it's not approved for pediatric patients at all. So I'm not going to go into this one because it really hasn't been studied well. And then in peds, and then bupropion, which is also known as Wellbutrin, actually gets great results when coupled with naloxone. But unfortunately, it is also not approved for pediatric use. And again, another black box warning. I know this. You're getting the gist by now, right? Contrave and Qsymia are the two major ones that seem to be getting the best results. They seem to be almost equivalent. But again, can't use it in kids. Or rather, it's not FDA approved. Doesn't mean we can't use it. We could use it, but you have to have a lot of consent signed with the family first. And I recommend having consent signed with any patients that you're going to start on any of these medications so that they are fully aware of what the signs and symptoms or adverse effects may be from the drugs. So when we look at weight loss medication in pediatric patients, we can see that the maximum weight loss, percent maximum weight loss was minimal going down the board. And then when we look at their final weight, when they kind of regained weight, it was minimal. And in fact, in three of them, they gained weight. And phentermine was really the best result that we got. So and this means that they lost 0.12% of their total weight. So it's not very effective. Now, this is an older study. We don't have great studies in adolescents looking at all these. So take this with a grain of salt. But this is what we have. All right. So then finally, the last metric that last intervention that we can do right now is bariatric surgery. So to be able to have a successful bariatric surgery program, you need to have a multidisciplinary team with a bariatric surgeon, which we have now, who we'll hopefully introduce you to. And Andrea will probably get to that in about 5 to 10 minutes if you want to let Nick know. And then you need to make sure you have a pediatric specialist, which all of you are, a registered dietitian with an experience in treating obesity. And we have a registered dietitian with experience treating obesity both in our pediatric weight management clinic and now also in the bariatric clinic. And then we also need a mental health specialist. And we do have psychiatry available for both those clinics as well. So what are the indications when you have someone who needs bariatric surgery? Well, BMI greater than 40 alone is good enough. And again, remember when we were talking about healthy interventions of diet, exercise, and psychiatry alone, those do not help our largest patients. So when they have a BMI greater than 40, you should really be considering sending them for weight management clinic and for the bariatric clinic. If their BMI is greater than 35 and they have any significant comorbidities, I've just listed only a few here. And in fact, we had a patient in the hospital recently with pseudotumor who did not get referred to anybody. Which to me is very concerning because her pseudotumor is not going to get any better without help. So then you want, anyone who has a debilitating aspect of life, you need to make sure that you're referring them. Now, when it comes to psychological disease, psychiatric disease, some may not be great candidates for bariatric surgery. I'm not going to go into those right now. Anybody who meets any of this criteria should at least be referred to the clinics so that they can get the best options possible. And worst case scenario, they see how serious you are. Now, I know a lot of pediatricians are concerned about destroying the family relationship when you start referring them to a weight loss clinic or bariatric clinic. And you do have to be cautious about that. But how many times have you looked in the mirror throughout your life and said, I need to lose weight? Everybody feels that way. Oh, well, maybe not everybody, but most people feel that way who are overweight or are living with obesity. And being able to talk about it in a positive way in your clinics is something that I will urge you all to invest some time in over the next 6 months to learn and to start to master. And again, that comes from the concepts of motivational interviewing, which I'll share with everybody later on. So there's a whole recommended selection of patients which you may have read through already. They do not necessarily have to fail 6 months of weight management because some of our patients need help immediately. One slide I forgot to include in this today is the preponderance of patients who died during our COVID surge in New York. And the one common characteristic between them all was obesity. Those patients who lived with obesity were hardest hit by COVID-19. So by improving their lifestyle immediately, we will be helping save more lives, hopefully, as we go. So just to quickly also show you what the different surgeries are, this is a Roux-en-Y gastric bypass. So initially, you're going to start stapling off the top of the stomach. The video is moving a little slower than I thought. So you staple off that part of the stomach, and then you're going to, okay, thank you. And then you're going to bring up part of the intestine to then drain from that pouch. So then that way you still have all your bile and other elements still coming through all the bowels, although it's not totally preventive from nutritional deficiencies and you need to wind up staying on supplements. And then the other most popular one throughout the country is the gastric sleeve, and this is the one that I believe Dr. Morin is preferring to do on any adolescent patients at this time, where you staple off the greater curvature of the stomach. Now, the other unique aspect that I didn't mention before about the sleeve gastrectomy is the greater curvature of the stomach is where ghrelin is produced. And by removing that aspect, you're reducing the neuroendocrine drive to be ferociously hungry. So that is one of the reasons we think it has a significant impact with minimal intervention as far as surgery goes. Adolescent surgeries are increasing throughout the country overall, and you can see that this is how many in 2018. We do not do the bans in adolescents in the United States. Surgeries equal or better in adolescents compared to adults, both for the two surgical procedures that I showed you. What's most important, I think, to take home about surgery is if 90% of our patients who are living with obesity are going on to become adults living with obesity. If they have surgery as adolescents, they wind up losing more weight for longer periods of time. Now, we don't have more than 8 or 9 years looking at these patients right now, but we're predicting that overall they'll have less chronic disease and a better outcome in life. When the gray line here is adults, the black line is adolescents. So after the same exact surgeries, the adults lost less weight, and then their ultimate weight loss was around 20%, whereas our pediatric patients was around 30%. And that's significant, and that can really change how their chronic diseases are. When you look at their chronic diseases, we saw that pediatric patients who are in black had significant resolution of the chronic diseases that they presented with before surgery, more than adults. So if we wait to help our patients before they become adults, we're committing them to potentially a life of chronic disease anyway. And all of this is not to just lose weight. It's not cosmetic. It's to help reduce early death, and it's helped to reduce chronic disease. And just to give you an idea, if we just looked at the pediatric curve here, at the top, those little red dots, that's from the other study if we plot percent weight loss from the medications that they were on. You can compare them. They're two separate studies, but just to give some perspective. Again, you wind up having remission of a number of different chronic diseases. The psychosocial benefits are all over the place. Some are saying that there's great ones. Other ones are saying that it's contaminated, or not contaminated, but the information that we have throughout the world is contaminated because of different rates of suicidality and depression throughout the world. I would never look at a study for Finland on this. However, most of the studies in the past year and in the past 10 years show that there is an improvement in anxiety and mood in our patients who undergo surgery. And then there are nutritional complications that can be seen, right? And these are all usually taken care of by supplementation, but there is a rate of noncompliance with vitamins where everyone would have to take place. And then complications from surgery is what everyone's going to focus on. So there were a number of studies that were put together to look at rates of complications in pediatrics and adults, and there were no pediatric deaths within 30 days. Actually, there was one, and it was a case report. It was not included in the larger studies, and that one case report was of dilated cardiomyopathy that was not diagnosed prior to surgery, and that's where the complications from within the first 30 days. And then when you look beyond 30 days, there were 3 deaths. Two were unknown, but they said that they were not necessarily related to the surgery, but they both had severe comorbidities. And then there was one that was a hypoglycemic event from the insulin they were taking. So we talked about this earlier, and that they can be a significant risk of death before the age of 35. But for each 0.5 BMI Z-score, so each change, remember Z-score, if we plotted along normal distribution and we turn them into Z-scores, each 0.5 change in Z-score you see down here decreased the risk of premature death. So we're coming up on our close of the talk here, and I want to focus on a few more numbers. So New York City, overweight and obese adolescent prevalence. So the total of overweight and obese together is around 27%. We have overweight at 16.3% and obesity at 13.5%, and severe obesity is around 5% within this group. The BMI of our adolescents seen in any one of our pediatric departments at Kings County since January are here. So with a BMI of 25 to 30, which is overweight, we saw 636. Again, this is not percentile, this is pure BMI. So that's 636. We saw 489 who are living with obesity and 118 that are living with severe obesity. Of those patients, 21 had type 2 diabetes, 17 had OSA, and 2 had hypertension in the obese group. And the group with severe obesity had 15%, 16%, and 15, 16, and 7, which are around 13, 14, and 6% respectively. And if you take all these numbers, those 78 patients, we're not even looking at the overweight group, these 78 patients, and I assume there's more because I don't quite trust Epic. I don't quite trust that we're coding everything appropriately either. That's not on you, that's on me. And I don't trust that I know how to use CICER, DICER, and Epic reports all that well yet. But what I can say is we definitely saw these 78 patients, and all of them should hopefully have been referred to a weight management clinic, either a bariatric clinic or the pediatric weight management clinic. And then the group with a BMI greater than 40, we should be trying to refer to our bariatric clinic. So again, I hope I met our objectives, that adolescents may need bariatric surgery and that it's safe, so are the meds we take. And that you know why your patients just can't lose the weight no matter how hard they're trying. And that you need to be referring overweight and patients with obesity and their families for help, or they may die prematurely between the age of 18 and 35. And since we may not have anywhere else to refer, we should be referring to ourselves, and we should all take it upon ourselves to take a much more proactive role, both in our community and in our hospital, to make this a much healthier place.
Refer your patients to our weight loss clinic. It's on Thursdays from 4 to 8 p.m., and this is the extension. This is our weight loss center, and the phone number, and our full team of the bariatric program to be able to refer patients for weight loss surgery to help save their lives. Thank you very much and have a great day.